Good afternoon, everyone. Welcome to Navigating Breast Health and Beyond. I am Denise Mananis. I'm the Senior Director of External Affairs for St. John's, and I'd like to welcome you all today. But before we begin, I would like to acknowledge my team, today's producers, Candace Cousins-Hopkins, my Associate Director of Marketing, and Nancy Nabi, our community liaison, who together put together this program for the community. I'd also like to thank our presenter today, Shari Rosenberg, and our IT department, without whom we could not do any of these modern technological webinars. Also, I would like to thank our community partners. Sally Pinto is from the Yonkers Neighborhood Naturally Occurring Retirement Community that is under the umbrella of the Yonkers Office for the Aging. And also Z Baird, who is from our Yonkers Public Library. So thanks to them, they help get the word out and get audience members to participate. This month at St. John's, we are celebrating MammoFest, which is our celebration for Breast Cancer Awareness Month. And this is the first event in that month of events, and we will have more information about what's coming later in the month at the end of today's presentation. So we want to get right to it, and I'm going to now introduce our speaker today. Shari Rosenberg has been a patient navigator for St. John's Riverside Hospital since May of 2010. Prior to St. John's, Shari was the Director of Patient and Family Services for the American Cancer Society. Shari's primary role is to serve as a proactive patient advocate by helping patients navigate through the healthcare system. She is also a certified navigator, breast advocate, awarded by the National Consortium of Breast Centers. While not a survivor herself, Shari was drawn to the field by her desire to help people when they needed it most, when they first heard the phrase, "You have cancer." So without further ado, I'd like to begin our discussion. Shari, welcome.
Thank you so much for inviting me today, Denise, and to Candace and Nancy, Joanne, and the rest of our IT team as well.
Thank you. So let's start by asking you a basic question. So you are our patient navigator. So can you tell us what that means? What do you actually do?
My primary role at the hospital as the navigator is focusing on women's breast health. I am following all the women that come into our facility for screening mammograms, breast ultrasounds, making sure they're coming back for their additional imaging, scheduling them for breast biopsies, and helping them through the continuum of care if they are unfortunately diagnosed with breast cancer.
Okay. Do you do other additional things like, so if they need connection to other doctors or making appointments for them?
Absolutely. My role spans across working with the women through the continuum, making appointments with their primary care, gynecologists, the breast specialist, and connecting them to all the local resources that we have available throughout Westchester County. I sit on the Cancer Coalition of Westchester, where we meet monthly with about 30 plus other community-based organizations, where we provide information to each other and enable all the individuals to go out and connect with resources in the community.
Very good. Before we get too far into more about what you do, in your bio, it says that you're certified. So I just wanted to ask you about that and what the difference between a lay navigator and I guess a clinical navigator would be, and which are you, and then tell me a little bit more about your training.
Absolutely. So when I initially started going into the field of patient navigation, I went through training initially with the American Cancer Society, and I went through their navigation program when I was there. Once I transitioned to the role at St. John's, I went to the Harold P. Freeman Institute and got certified through the Harold P. Freeman Institute back in 2012, and then took it a step further for a more advanced certification with the National Consortium of Breast Centers. That I had to sit through a 3-day program, take an exam, Every 5 years, I need to take an exam again. And each year I have to participate in a certain number of continuing education credits in order to hold up that certification each year.
Okay. Just so the audience knows, if you feel like asking questions, you can put the questions into our Q&A line, and at the end of the presentation, I have some questions also, and then I will read any of these questions, so stay tuned, because I just saw a question pop up. So anybody else who feels the need to put that in, do so please. Okay, that's wonderful. So a lay navigator is different from a clinical navigator.
Correct.
And so clinical is somebody who's generally a nurse.
Typically, a clinical navigator is either someone that has an RN degree or even an NP. So there's a difference between lay and clinical, where I can help all these women through the continuum of care, but I am not able to provide medical direction when it comes to what their treatment needs are and or their full treatment of care from diagnoses and beyond.
Okay. All right. So, I wanted to just talk about some basics too about breast cancer and screening, and the American Cancer Society mammography screening guidelines seem to be of a confusion now because the age keeps changing.
Yes.
Can you sort of go over what is appropriate given your age, what
Absolutely.
you should be doing?
So the recommendations now from the American Cancer Society are any woman between the ages of 40 and 45 have the ability to have those discussions with their primary care or their gynecologist to discuss starting routine screening yearly. 45 plus, then that is more encouraged for the yearly screening. Again, between 40 and 45, not every doctor is necessarily promoting the yearly screening, so that's up to the individual and their doctor. 45 and up is when that routine screening does occur, according to the American Cancer Society. St. John's Hospital, we advocate and promote for yearly routine screening. However, the United States Preventative Task Force has slightly different guidelines than the American Cancer Society. For women 50 and up, they are recommending, or they continue to recommend, routine screening every 2 years. So there is a difference in recommendations, guidelines, depending on the servicing organization. But again, St. John's, we primarily advocate for women to come in every year because so much can happen in a woman's, in a woman's life in that 1 year.
Right.
There are diagnoses that do pop up in less than 2 years.
So those are general guidelines, but what
Correct.
about if a woman has been designated to be at higher risk? So how does that impact what she should be doing?
If a woman is at higher risk, especially if she has a BRCA1 or 2 gene within the family, then typically what happens is they need to be connected to a breast specialist, likely be connected as well to a genetic counselor, and they need to work backwards from what they have in their family history. If their mother was diagnosed, let's say at age 40, then that woman needs to start testing at age 30. It's always 10 years earlier than when that immediate relative was diagnosed with breast cancer. So the age does start much earlier if you are at higher risk. And also your breast density will make a difference as well. One of the laws that came out for New York State back in 2014 was that any woman with dense breast, it was encouraged for them to have a routine screening breast ultrasound connected with their mammogram because of the breast dense tissue. But that is something that your doctor and or a breast specialist would be able to determine. A woman can't determine herself whether or not her breasts are dense.
Okay. Can you tell me what you know, we're still sort of in the COVID pandemic, and even though locally our numbers seem to be, you know, sort of better. But can you talk about having a mammogram based on getting the vaccine? And I know that a lot of women have delayed having their screening during COVID, but can we speak to both of those issues?
Absolutely. The most important thing is to continue with your routine screenings. That's what's most important. However, there has been a guideline since the vaccines have been out. Radiologists were noticing that there was some imaging that was coming up. There was inflammation in lymph nodes on the side where a woman had gotten the vaccine. So the recommendation is it either needs to be done prior to your first dose or at minimum 4 to 6 weeks after your second dose. So again, we don't want women to keep delaying their screenings because the screening is what's most important, but you do have to take into consideration the time frame of which you did receive the COVID vaccine.
Can you speak to some of the precautions that we have in place here in our facilities so that there's a comfort level for people coming in to have these screenings?
Absolutely. When you come in the front door, our security guards stop every visitor at the door. They are given a visitor pass, their temperature is taken. Once they get to the registration department, there are hand sanitizing stations along the way. All the desks are sanitized after every patient comes in and registers. When they come into the mammography department, we also have another hand sanitizing station. Everyone has to sanitize their hands prior to being given a clipboard for them to fill out their paperwork. That's set aside. When the patient fills out the paperwork, the clipboards are wiped down after every single patient, in addition to the machines in the rooms as well.
That's great. Okay, because I think people need to have a sense of the comfort. And also, I should just say that one of the things that the hospital has done during this pandemic has really invested in the technologies associated with cleaning and disinfecting. We do have an ultraviolet robot that goes in and cleans and sanitizes. We do have those sort of Ghostbuster backpack spray things that go in and sanitize, and we have an incredible environmental team that go in and make sure that our facilities are clean, just so that our community knows that that we're really trying to take care of things to make it possible for them to continue to get their care. Okay, so moving along, I wanted to talk about how common breast cancer is. Because, you know, we hear about it all the time. We do these annual celebrations. And I think, you know, after a while, people are like, okay, yeah. It's, you know, we've heard about it. We know about it. And then they kind of forget. So Can you talk about the prevalence of breast cancer?
Unfortunately, still 1 in 8 women will be diagnosed with breast cancer in their lifetime. So again, the importance of the routine screenings, keeping up on that imaging and making sure if we're recommending you coming back for additional imaging, that you come back for that appointment. Again, as a navigator, that's one of my larger focuses, is to make sure those women that need, whether it's an additional diagnostic mammogram, additional ultrasound, or breast MRI for further imaging, to make sure that they're coming back in. If they don't come back in within an allotted amount of time, we send certified letters so that we know that we've been covered in terms of reaching out to them with several phone calls, several letters, so that if unfortunately at a later date they may be diagnosed and they did not come back in for that additional imaging, the hospital itself is covered, that we did do our protocol in terms of getting them back in, but they were non-compliant with our recommendations.
Okay. Can you talk a little bit about what actually is breast cancer and how it sort of manifests. And then I do want to talk about men too, because this is something that does affect men, although fewer men. But in terms of, what is it and how does it present in the breast?
Breast cancer is a cancer. I mean, cells form within the body that are abnormal. Now, a breast cancer can be in the form of a lump, and or it can be calcifications, which is not something you would ever know of or see. That's something that is seen under imaging, whether they find it under mammography or possibly under breast MRI. Lumps can be seen typically under mammography, breast ultrasound, and or MRI. So certain types of tumors are not seen under different imaging. That's why certain additional imaging is requested depending on what the radiologist sees, and then their findings are accordingly. Men, yes, they absolutely can get breast cancer. A lot of men think that they can't because they don't have breasts, but even though they don't have actual breast, it's breast tissue. It's no different than a woman who may be flat chested. What's most notable, even more so in men, is they will see and or feel a lump. Now, sometimes it can be something called gynecomastia, which is something that is typically seen in men. But for when a man does feel a lump, not only does he need to go see his primary care or a breast specialist immediately, because that's something out of the norm, they will be sent for what's a diagnostic mammogram and ultrasound, so that they can see what's going on within that chest wall.
I wanted to sort of go back and talk about the lumps that present. Can you talk about the different kinds of lumps and whether they're all cancerous or are some benign?
Not all lumps are cancerous. Absolutely, there are lumps that are called fibroadenomas. They are benign lumps that the tissue is in the breast, which the only way to know that it's a fibroadenoma, which is a benign tumor and or a malignant tumor, is through a breast biopsy. Now, some fibroadenomas, depending on their size, may need to be removed completely. When a woman is recommended for breast biopsy, typically it's either an ultrasound guided biopsy or a stereotactic biopsy. And those are done by the radiologist in the hospital. Those are done under local anesthesia. You're awake for the procedure, but the breast or chest wall, if it's a male, they use lidocaine like they do in a dentist's office to numb the area in order to do that biopsy. They remove a small amount of tissue, which is then sent to the pathology department, and those results typically come back within a week. Again, whether being benign or cancerous. But the larger fibroadenomas sometimes need to be then removed through what's called an excisional biopsy. And an excisional biopsy is done by a breast specialist in the OR. So that is a different type of biopsy than ultrasound and stereo done by the radiologist in the hospital.
Okay. I want to save the discussion about prevention to the end, and so I do have some questions that are coming in, and I want to go to those first. Mm-hmm. But this is an interesting one, because I know that when it was my first time to have a mammogram, I was curious as to what it was going to be like and whether or not it was painful. So the question is, are mammograms painful?
They are. They're not necessarily painful for everybody, but when you take a breast or chest wall tissue and it has to be compressed to a certain number in order for the proper imaging to be done, it's a tight squeeze. So we will always alert women. Pain tolerance is different depending on the person. Some people, they do not have any pain whatsoever, and others do have some discomfort. But what we try and do is ease the woman's thought process and ease the pain in the sense of, you know, some deep breathing. And even when you're in the mammography room having the mammogram done, you actually have to hold your breath for the 15 seconds when they're taking those pictures. So it's a deep breath in through your nose, holding it, and then releasing it once the picture is done.
Yes, I'm familiar.
We're all too familiar.
So in terms of the actual biopsy, I mean, you know, people in pain, right? So this is the question. Is there any pain medication recommended prior to a biopsy? Would you recommend something to relax someone? Is there a local anesthetic? I mean, you know, lidocaine is used in various other kinds of procedures to sort of numb the pain. Is this something that's used for a biopsy?
So for breast biopsy, what a woman or a man needs to do prior to the biopsy, whether it's a breast or any other part of the body, you have to be off blood thinning agents and anti-inflammatories for at least 5 days. So no Advil, Aleve, Motrin, Naproxen, baby aspirin, regular Tylenol is okay. So if someone's very anxious about the biopsy itself and the pain, they can take Tylenol beforehand. But even within 24 hours after the biopsy, you still have to refrain from anti-inflammatories and aspirin derivatives because they don't want to have any additional unnecessary bleeding. For the actual biopsy day of, when they use lidocaine like they do in a dentist's office, that just numbs the breast. It alleviates that pain because it's a numbing agent, but once the numbing agent wears off, anyone's going to have discomfort on that side, probably for up to 24 hours. And again, everyone's pain tolerance is different. There are some women who come in and they say, it was a breeze, it didn't bother me at all. And then you have other women that are coming in and saying it was, you know, one of the more painful things I've experienced.
Okay. Someone wants to know, when they have a mammogram, they've heard that they can't use any kind of lotion or deodorant or, you know, other things. What are the rules?
Yes. So for mammogram, you are not supposed to wear any lotions, perfumes, and or deodorant. Now, if a woman comes in for their mammogram and they've forgotten to take off their deodorant, we do provide wipes that they use to remove the deodorant, but it's highly suggested to do a very deep cleaning in the armpit area and even into the chest wall, because sometimes the residual deodorant, which depending on what type of deodorant you're using, if you're using a typical deodorant that has some essentially metal in it, then that could come up and show in the pictures on mammo, and then you may need to come back for additional imaging that may not have been necessary had the armpit areas been fully cleaned.
Okay. I wanted to go back to the men for a second and ask, are there different signs that men should be looking for, or are they experiencing the same sort of, I felt a lump or something else that are they the same or different than what a woman presents with?
Typically for a man, it's going to be that they felt a lump.
Okay.
Yeah, and or quite possibly where there could be some spontaneous nipple discharge, which is clearly abnormal, but for male, typically a lump.
Okay. So someone wants to know, one of our audience members is asking about the risk of radiation exposure from a regular mammogram and having that every year.
It is such a minimal amount of radiation. It does not affect your body where you're going to go off in a metal detector. Mammograms wouldn't be done for all these years to protect women and their breasts if there was extensive radiation. It is perfectly fine. Not only can you come in every year, but it again is that minimal amount of radiation if you need to come back for the additional imaging. It's not going to affect your body, you know, in a way that's detrimental in any way.
Okay, so now I wanted to talk about breast cancer prevention. what can women do? I know that obviously for the women who have a genetic predisposition, but if you don't know you have one, what do you do for those folks, and what can you do just in general to prevent breast cancer?
In general, to prevent breast cancer, obviously staying up to date on your routine screenings is most important. In addition, keeping up with exercise. Exercise is one of the most important things, whether it's for breast cancer prevention or any other cancers and or hypertension, heart disease. The more rigorous activity you could get in each week, the better. At minimum for adults, they're saying at least 150 minutes of moderate to rigorous exercise to keep your weight down. If you are obese, that puts you at higher risk for breast cancer. In addition, limiting alcohol use. Again, there's nothing wrong with a social drink here and there, but the more alcohol you drink, the more higher risk you are for breast cancer and other types of cancers as well. But for those that are in the higher risk category, they need to be connected with a genetic counselor early on to go for gene testing to see where they are possibly within their family history, and sort of do the comparison to see where their immediate family is and where they are, and then determine what their routine yearly screening protocol will be.
So if I'm sitting out here in the community and I am 30, which I'm not, but if I were that young and I didn't know whether or not I had a genetic component, but my aunt had breast cancer and somebody else had ovarian, or my father had prostate cancer.
Yes.
What are the tip-offs for somebody to potentially go and seek some kind of genetic counseling?
Exactly what you just said. Anyone that has a first-degree relative that has had a breast cancer or an ovarian cancer, or a dad that's had prostate, you should absolutely talk to, whether it be your GYN or your primary care, about seeing a genetic specialist. Now, depending on the insurance company, is which insurances will cover the actual genetic testing itself, how much they can cover and what you might have to pay out of pocket. But knowing where you sit within that category, to me, is, the expense is warranted to know what can I do proactively to help me and my family and even your offspring as to how you can go about your routines going forward.
Very good. So, okay, I think this is our last question. If someone comes for their annual screening,
Mm-hmm.
and they find from the screening that there's something present, and what's the process? Talk to me like it would be me. I'm sitting in, I get the phone call from you. Is that how that works? So what happens?
Yes. So so mammograms are read on a BI-RAD scale. So BI-RAD 1 and 2 is something that's normal. BI-RAD 0 is where they need to come back for additional imaging. And BI-RAD 4 and 5, there's already an abnormality showing up and they need to go for biopsy. So all of the women that have BI-RAD 0, 4, and 5, it's my job to connect with all of them and make sure that they're either coming back in for that additional imaging and or scheduling them for biopsy with the radiologist, or connecting them to a breast specialist if that's where they're more comfortable going. The phone calls are made, we get them back in. Anyone that has a BI-RAD 0, once they come back in for that additional imaging, it's either determined that with that additional imaging, they found that everything was normal, and then they come back a year later, or there's something there, it's not abnormal, but it might still have a little bit of question where they're suggested to come back in 6 months, or it leads to a possible biopsy if they see that there is a true abnormality.
Okay. So when you get them on the phone, they come back in, you're connecting them. Now let's fast forward. If they do in fact have breast cancer, they go through whatever the doctor has recommended and the surgeon or the medical oncologist, and they have a treatment plan in place. And then what's your role sort of through that process and then post that process?
So when a woman is diagnosed with breast cancer, when the pathology comes back with a malignancy, it's my job to make sure that either the radiologist is contacting that patient with the malignant findings and or their physician. I am not allowed to let a woman know that she actually has the diagnosis since I am not a clinician. So again, that's up to the radiologist and or their primary care or GYN. From there, once they're notified of the diagnoses, I then reach out to them to say, you know, I'm here for you as the navigator to get you connected to our local resources. Make sure that you're having no issues with connecting with the breast specialists. And I work with the breast surgeons in the hospital in making sure that their surgical cases are coordinated properly here at the hospital. And then I will meet with those women when they're coming in for surgery to make sure, has the process been smooth for them? If there wasn't, what can we do? What can we do to fix it? I typically, meet them when they're in the mammo department for what's called a needle localization and or nuclear medicine, which is a lymphoscintigram, which are additional exams that some women need going into their surgical procedure. So I meet with them there, and then I check on them once they come out of surgery to make sure everything's okay and reassure them that I am here and I am accessible to them through the continuum of care and into their survivorship.
Very good. All right, well, I do have one question. I'm not sure that you're going to know what this is, but it says, are you familiar with the new portable non-invasive device? And I'm not sure what it's for. Is it for, it's for ibreastexam.com is a website that must have a device that maybe you've heard of something for biopsy or for, I'm not sure. You know,
I'm not familiar with, no, but that's something that we could do some research and find out from our breast specialists.
Absolutely. Okay, so that's it for our questions. And before we end, we do have a few things that we want to talk about. But Shari, thank you so very much for kicking off MammoFest month at St. John's for us. You were wonderful, and we appreciate the information and all that you do for our patients, because it's tough stuff that you do. It's really, really appreciated.
Tough and rewarding at the same time.
It's good. Okay, so what do I need to tell our folks here on our call? So if you want to talk to Shari, that is her phone number, 964-4327. You can always email her. If she is unavailable or dealing with a patient, leave a message, she will call you back. What's our next slide? Okay, this is our schedule for MammoFest. You can see that we are doing, we sell all kinds of pink goods that the proceeds of which support education materials and things that we need for the hospital to give to our mammography suites and also to our breast cancer patients. On the 20th, we are doing another webinar with our new breast surgeon, that is Maureen McAvoy. And she will be talking about the new things that are happening in breast cancer treatment, both surgical and non-surgical. And then finally on the 27th, and we invite our community to participate in this, we do an annual event here at St. John's and all of our facilities called Get Your Pink On. So we invite everyone to wear pink, take their pictures, take your selfies, send them in to us at info@riversidehealth.org, and we will post it on social media as we celebrate the close of Breast Cancer Awareness Month and MammoFest. And then what else do we want to tell you? So yeah, our mammograms, we do have 3D mammography suites in both our Andrus Pavilion and in our Dobbs Ferry Pavilion. So if you need to schedule, please do so by calling 964-4329. And I think there's one more. Yes, that is our virtual urgent care. I know we referenced the fact that many people are a little concerned about coming in for care based on COVID, but we do want you to know that this has been a wonderful tool, virtual urgent care, and that number is 964. Oh, good Lord, it's 4429, I think it is. 964-4429. Yeah, I was right. Isn't that a beautiful thing? And then finally, if you just have general questions, please email us at info@riversidehealth.org. And if you need a physician, we are happy to do a physician referral by calling 9644-DOC or find a doc at riversidehealth.org. Thank you again for joining us today, and thank you, Shari and my team. You all do a great job. Couldn't do it without you.
Thank you very much for having me.